Sit the patient and gather a history, and explain that you will apply anesthetic drops that's simethicane to the eye. State that these will sting or hurt a little bit. Please note, tropicamide is not local anesthetic, it dilates the pupil. Once local anesthetic is in, emphasize how painless the procedure will be, and then clear the room of distracting carers or family. Apply 2 drops to the cornea. Get the patient to look up and hold the lower lid down and ask them to blink once the drops are in place. Generally, this reduces symptoms and makes further examination more comfortable and effective. Measure visual acuity in each eye using a Snellen chart. Keep glasses on if required when testing visual acuity. If vision not optimal, for example when glasses are not available, assess using the pinhole. Sit the patient with their chin on the rest and forehead against the strap. The black line on the bar should be at the level of the lateral canthus of the eye. Set the light filter to produce a bright white light. Increase light beam height by rotating the dial on the illumination tower. Note that turning this dial fully until it clicks gives us the blue light used in the fluorescein exam. Note this green or red-free setting is not generally for ED use. It is not used for the fluorescein exam, but for looking at the retina. Set the width to 1 mm or 10 on the scale of the dial. Have the swing arm at 45 degrees to reduce light reflection and improve depth perception. Examine the unaffected eye without fluorescein. Then examine the affected eye without fluorescein, looking for signs of a penetrating injury. See these in the written section under contraindications. This is important. Using a cotton bud, evert the lower lid and examine for foreign bodies. Scanning the whole lower lid. A tip to evert the lower lid is to place the cotton bud just below the lid margin. Push gently in and down and rotate the bud clockwise. To evert the upper lid, hold it proud of the eye by the eyelashes. Use the cotton bud to push the lid and evert it. With the lid everted, scan across looking for foreign bodies. Remove with a cotton bud using a rolling motion. If corneal foreign body is located, explain the techniques to the patient. First, if it appears new and not embedded, use a cotton bud. Second, that you will use a needle held parallel to scoop the foreign body off and that you will not penetrate the eye. As a rule, keep the slit lamp light to a minimum and out of the pupil. Attempt to remove by gently dabbing with a sterile cotton bud. If unsuccessful, use a 23 to 25 gauge needle held between the thumb and the index finger. The needle can be bent or attached to a small syringe to improve angles and control, and this is a personal preference. Look around or over the lens of the slit lamp until you see the needle come into the light, and then lower your head to look through the lens. And use magnification to guide the needle onto the surface. The middle and forefinger are used to fix position and keep the lids open. Then, under magnification, keeping the needle tip as parallel as possible, use small movements to pick up or scoop the foreign body away from the cornea. So key steps are to have the needle held by the anchored hand close to the cornea, and then pick up the magnified vision and scrape or flick off the foreign body with the beveled needle tip.
This is Dr. Brendan Cronin from the Queensland Eye Institute, demonstrating corneal foreign body removal, which is a common presentation to ophthalmologists. These 7 points are critical to follow to ensure you have a good safe technique and a comfortable patient for this procedure. As you can see here, there's a peripheral corneal foreign body that's quite metallic in nature. I'm using the needle and keeping it parallel to the eye to easily remove that little foreign body there that had been in for a couple of days and so had rusted into the eye. A lot of these foreign bodies are sharp metal objects. It's important to have previously ruled out a penetrating injury in all of these patients. That would obviously be a significantly more invasive procedure to have that removed and will often require a vitrectomy. You can see with all of these procedures, I'm using a needle that's just kept parallel to the eye, with the patient fixating in the distance and the light is kept out of the pupil. It's important to caution all of these patients about the importance of safety eyewear to ensure they don't get a nastier injury next time. It's also important that the fornices are examined thoroughly and the upper lid is averted to ensure there's no hidden foreign body.
Once the foreign body is removed, apply fluorescein to check for corneal leak and then measure and document the size of the epithelial defect. Remember the blue, not the green light, as mentioned earlier in the video. Here is a Seidel's sign demonstrated in a video from Dr. Surjan Patel. Use the cobalt blue filter as we've discussed earlier. We can see the laceration in the eye, and we can see the blue area as the fluorescein is displaced by the leaking aqueous. When the patient blinks, the laceration and then the leaking aqueous is where the fluorescein is cleared by the aqueous as it flows.